session, Path to Diagnosis, Understanding Your Rare Kidney Disease Cause. Special thanks to Novartis and Otsuka for their sponsorship of this session. So my name is Yoshio Hall. I am a professor of medicine and a nephrologist at the University of Washington. I'm also a former American Kidney Fund board member and recipient of the Clinical Scientist in Nephrology Award. And so in this session, we'll hear about the path to receiving a rare diagnosis. Our first speaker will review rare kidney diseases such as IgA nephropathy and complement 3 glomerulopathy, and then share how to get tested for a rare disease. And then our second speaker will share her experiences about receiving a diagnosis of C3G. And now it gives me great pleasure and honor to introduce our speakers for today's session. So our first speaker is Dr. Laura H. Mariani. Dr. Mariani is a nephrologist and clinical researcher at the University of Michigan in the Division of Nephrology. She completed her medical school training at the same institution and then subsequently went on to the University of Pennsylvania, where she completed her residency in internal medicine, her chief residency, her nephrology fellowship, and a Master's of Science in Clinical Epidemiology before returning to the University of Michigan, where she is now an associate professor of medicine. Her primary clinical and research interests are in observational studies in glomerular disease. She has a very large footprint in numerous clinical and translational NIH-funded research studies in this space. So welcome, Dr. Mariani. Thank you for being here. Our second speaker is Ms. Michelle Farley. Ms. Farley is a PhD candidate and a researcher in biological anthropology. She was diagnosed with complement 3 glomerulopathy in 2018. However, she'd been noting abnormal blood work and experiencing symptoms for well over a decade before receiving her diagnosis. She progressed to kidney failure and started at-home dialysis in May of 2023. During this entire time, Ms. Farley was still pursuing her doctorate degree and working part-time as a teaching assistant and instructor for college courses. On May 3rd of 2024, Ms. Farley received her first kidney transplant from a live donor and a close friend, and she's now enjoying getting to revisit some hobbies and activities that she had been physically unable to perform during the peak of her illness. And so thank you both for being here today. I'm going to pass this session over to Dr. Mariani to share your overview of rare kidney diseases. Dr. Mariani.
Great. Thanks so much for that kind introduction, and thank you to the American Kidney Fund for allowing me to participate in this webinar. I'm delighted to be here. I'll just start off with some of my disclosures, which are listed here, including research in this field and working with some companies in this area. On the next slide, I'll go through sort of what I wanted to cover today. So first, I want to talk about kind of what is rare kidney disease. There are actually many, many causes of kidney disease. I want to talk about which ones I mean when I use the word rare kidney disease. And then there are so many that I thought we'd just talk about one in particular. So we'll take a deeper dive into C3G. We'll talk about how it's diagnosed, what we understand about the biology and the cause, and sort of what we're looking forward to in terms of treatment options to really prevent progression of the disease. And then at the end, we'll talk a little bit about some kind of key takeaways for people who are dealing with rare kidney disease. All right, so let's start out on the next slide with what are rare kidney diseases. So what you'll see on the next slide is, if you look across the whole United States, and you took everyone who ended up having kidney failure, meaning ending up on dialysis or needing a kidney transplant. In this graph, you can see that those big bars are all the people with diabetes and high blood pressure. And those are far and away the most common causes. And in that third bar, you'll see glomerulonephritis, and that's the bucket of things that are really much more rare kidney diseases. You'll also see some other rare genetic diseases as well. So overwhelmingly in this country, the most common cause diabetes and hypertension, but certainly there's lots of patients that also have these more rare types of kidney diseases. And on the next slide, there are, even in that little bar, there are actually many, many diseases that fall in that rare kidney disease, and they can be caused by lots of different things. So they can be autoimmune diseases, meaning the immune system is attacking the kidney. They can be genetic, they can be as a result of either infections or medications or cancers, or they can be what we call kind of idiopathic, meaning we don't really understand the biology yet, but we think it's something that's triggered this bad reaction in the kidney. In adults, for rare kidney disease, usually that means people have to get a kidney biopsy to make sure that we can understand the exact injury to their kidney. In children, there's one kidney disease that's more common in kids than anything else. And so oftentimes little kids will get started on treatment. And then if they don't respond well to it, then they also can get a kidney biopsy. And in the end, the reason the kidney biopsy is so helpful is that we can look at the actual filters of the kidney. These are called glomeruli. And depending on the pattern of injury that we see in those filters, that's often how we give the disease a name. And so that's why some people will say rare kidney disease, other people will say glomerular disease, because that means the filters of the glomeruli are damaged. All right, on the next slide, I just wanted to say a little bit more about those special filters of the kidney. So, most people have two kidneys. They get blood supply almost directly off the aorta. And as that blood supply goes through the kidney, it branches into smaller and smaller pieces until finally it makes this tiny little tuft of blood vessels. They're almost small enough that they're just a little bit bigger than a single blood cell. And that final tuft of very tiny blood vessels, that's what the glomerulus is. And that's where urine first starts to be produced. It's kind of like a colander. So as blood comes in to be cleaned, good things are supposed to stay in and only bad things are supposed to come out. And it's those filters that get damaged and attacked in these rare kidney diseases. On the next slide, I mentioned already that what we really need to know is what's happening to those little filters. And I wish I could say that ultrasound machines or things like that are good enough to be able to look down in those tiny features, but usually they're not. And what we need is a small piece of tissue to actually be able to look at those glomeruli under the microscope. So typically what I ask my patients to do is come in for a kidney biopsy. It's typically an outpatient procedure where under an ultrasound, we can take a small piece of that kidney. You can see in that middle column there, it's about as big as like a pencil lead that we can actually look at it and see kidney tissue there. They then put it on slides and we can look at it under the microscope, which is what that pink picture is. It's essentially a bread slice through one of those filters of the kidney and can really tell us what's happening there. On the next slide, once we get that tissue and look at it under the microscope with our pathologists, that's where we can see what type of damage is going on. And so that's why a lot of these rare kidney diseases have names that are really describing the damage that we're seeing on the tissue. So for example, minimal change disease, that's the one that little kids get most often. Essentially, when we first look at it under the microscope, it doesn't look that different. It's only when we look at really high power that we see one cell in the kidney has changed its shape. And that's probably why they're leaking so much protein in the urine. The next one is called focal segmental glomerulosclerosis. This is where when we look at those little filters, some of them have a big scar in them. So part of that filter has been replaced by scar. Another example we might see is something called membranous nephropathy. This is where we know the body is making an antibody that's recognizing part of the kidney as foreign. And so when we look at it on the microscope, we can see these immune deposits that are kind of lining and gumming up the colander of those filters. And it's a very characteristic pattern of injury. So even though on the biopsy under the microscope, these look very different, all three of these diseases often present the same way. So patients will show up with protein in their urine, or they'll start to complain of swelling. Little kids tend to get it around their face, but adults get it in their legs, and they'll start to gain fluid weight, and that's usually what presents. And actually, all three of those diseases can do that same thing. It's called a nephrotic syndrome. And that's why the biopsy is so helpful for us to know what exactly is going on with those filters. On the next slide, you can see two other examples of damage, some of the ones that we are going to talk about today. So these ones tend to be a little bit more inflammatory. So those ones I just mentioned, they tend to damage the filters such that protein gets through. But for these diseases, there can be a lot more things that are getting through that colander. So for IgA nephropathy, this is again where the body is making an antibody that kind of gets stuck in the kidney and it triggers an inflammatory response where the immune system is really way too active in the kidney. C3G, C3 glomerulopathy, this is again where part of the immune system is just way too active and it's preferentially depositing in the kidney and triggering inflammation there. These diseases also can share features. So this time patients might get picked up by abnormal kidney function testing where the kidneys just aren't able to clean the blood the way they usually do. Again, you can get protein in the urine or blood in the urine. And it's really that biopsy that helps us figure out what's actually going on. All right, on the next slide, I couldn't show you all of them today, but there's many, many more. Many different patterns of injury and disease processes, other autoimmune diseases like some of the ones I've listed here. There are also genetic disorders which can cause damage to those structures of the kidney and damage those filters as well. They're so delicate that actually there's many different ways that they can be injured. All right, on the next slide, let's just take a deep dive just into C3G. I don't have time to go into all of the kidney diseases, but I think C3G is a good example of, I think, kind of how far we've come to try to better understand what's causing the damage and kind of give us hope in the future that in the future we'll be able to have more options than we currently have today. All right, so how is it diagnosed? I think probably this isn't going to be a surprise, but on the next slide, you can see that we really need that kidney biopsy. So when patients first show up, it's often young adults. So the typical age of diagnosis, maybe not when symptoms first start, but the typical age of diagnosis is around 30. Like many of these rare kidney diseases, people present with blood in their urine or protein in their urine. Sometimes you can see the blood, sometimes you can't. Sometimes the protein, you see really foamy urine, but sometimes not. Like I said, they may have swelling and low kidney function. And then because this is a problem of complement, we'll come back later, there's a complement level that's sometimes done in the blood. But you can see kind of each person can be different. So on the right side here, I have this table, which really looks at kind of a small group of people that have this condition. And you can see that not everyone has exactly the same presentation. That's why it makes it so hard to diagnose and to pick up. All right, on the next slide. This is where that biopsy is so helpful. So in this biopsy, the way those filters are damaged is when you look at, we do 3 special types of stains. The first one we just look at under a regular microscope with a regular kind of stain. That's called light microscopy. And if we look at that filter, it just has way too many dots. So this should be nice and open. The blood should be able to freely flow through it. And you can see there's just too many cells here. Sometimes the pathologists talk about this looking like cauliflower, like a head of cauliflower, where there's just too much clearly being deposited there. And when then they do 2 other special stains, one's called immunofluorescence, one is called electron microscopy. Here's where we can see this protein called C3 is being deposited in the kidney and triggering all of that inflammation there. On the next slide. So why are we seeing that C3 being deposited in the kidney and triggering inflammation? So I mentioned the complement system earlier. This is a really complicated part of our immune system. But essentially what this is it's kind of a front line of defense for infections. And it's kind of a complement cascade that's always on. So you can imagine it's kind of always at the ready to attack something. And it can be triggered different ways. It can be triggered by antibodies. It can be triggered directly by pathogens. It can be triggered by damage in the tissue that our body recognizes. But essentially, the body sort of recognizes something bad's happening and activates this complement system to attack it. And so it's sort of primed to be dysregulated. All right, on the next slide. like I said, because that you saw from that diagram how complicated, how many steps there are, how many places converge, you can imagine there's lots of places where that can go wrong. And so that in that complicated web of our complement system that's constantly being turned on and turned off, there are lots of ways that can get disrupted. So you can have genetic variations at all of those different steps. You can develop antibodies, which basically either step on the gas or remove your brake. You can have antibodies that are like an autoimmune disease, or that can be triggered by other things like infections or cancers. So all sorts of ways that the system can get way too active. All right, on the next slide. Essentially, when we're trying to figure out what's gone wrong with the complement system in someone with C3G, we're essentially trying to test that complicated system. So we want to know, where is it too active or where is it underactive? And there's specific testing that you can send to find out, does someone carry a genetic variant that their complement system is prone to being too active? Or is there some antibody or something else that has happened that's turned the complement system on in this way? So in this whole complicated system, we've learned so much about all the different steps, all the different gas, all the different brake, and you can now test for all those different pieces there. All right, on the next slide. So as you can imagine, this is such a complicated disease to diagnose that the journey can take a long time. So first, patients can present with symptoms that you can see overlap with all those other different kinds of rare kidney disease. We know something's wrong in the filter, but there's many, many different things there. And sometimes it can be subtle and be missed, attributed to a urinary tract infection or something like that. So it can take a long time for maybe even someone to realize there's a kidney problem. Once there's some time it might take to get that kidney biopsy. But for C3G, once you get the kidney biopsy and you see the complement system is active, you then have to continue the journey to figure out, why is the complement system too active? And that's where you can do that functional testing, that genetic testing, to try to figure out exactly what's happened. All right, on the next slide. And the reason coming all the way through that pathway is challenging is this is a rare version of a rare disease. And so I think if you ask nephrologists across the country, probably many, many nephrologists have seen only a handful of these patients, or maybe not even any yet if they're early in their career. And so this certainly is a challenge for primary care doctors, but it's even a challenge for specialists. And so that makes it, really hard to make the diagnosis. And then going forward, because the treatments are potentially toxic and hard to access, or there aren't good treatments for C3G and other rare kidney diseases, getting on a good therapeutic regimen sometimes can be a long, drawn-out process. All right, on the next slide. Okay, what about treatment? So in terms of new discoveries, so like I said, I think what's been so exciting about C3G and actually several of our rare kidney disease is the advancements that are being made in understanding the underlying biology. So on the next slide, so for a lot of our rare kidney diseases, C3G included, we know a lot now about kind of good things to protect the kidney in general. So of course, those really delicate blood vessels, they're really sensitive to high blood pressure. I don't want pressure pounding away on my little delicate blood vessels. So good blood pressure control, good weight management, low salt diet, all of those things will really help. They're also good medicines that no matter what type of kidney disease you are, we know that they're protective long term. So those are blood pressure medicines called ACE inhibitors and angiotensin receptor blockers. Before we really knew a lot about C3G, a lot of us tried various different immunosuppression. So we tried things called like mycophenolate mofetil, rituximab, eculizumab have been tried. These are all immunosuppressants where we're just trying to quiet down that inflammation in the kidney. But there wasn't, those are all medicines that are used for a lot of autoimmune diseases. There wasn't really sort of specific medicines designed specifically for C3G. So for a long time, our best hope was to enroll patients in clinical trials that were testing out new therapies for these diseases. And you can see that like with this kind of general management on that pathway there, the risk for this particular disease where we didn't really understand the biology, didn't really have targeted therapies, it's actually unfortunately very common that people lose their kidney function over time. So you can see here in this paper, the treatment and the outcome for C3G patients, you can see it was 87 people. And essentially over the course of this study, 40% of them had progressed to kidney failure. So we just knew that we probably, with the tools we had in hand, we're certainly not delivering the outcomes we wanted for this group of patients. Just too many of them were progressing to kidney failure. All right, on the next slide. This is another picture of that complicated complement system. So again, this time the complement system is kind of flowing from left to right. Left side is kind of all the triggers that kind of get the complement system started. And then you can see as it cascades through to this final complex, there's all sorts of control mechanisms there. So that's bad because it's complicated, but good because there's a lot of places potentially we could intervene on, and lots of places that maybe if we developed therapies for, maybe it would be able to slow down this complement activation. Okay, on the next slide. And this is just to highlight some ongoing clinical trials. So while right now there are not yet FDA-approved therapies specifically for C3G, you can see that as we've learned a lot about that complement system, there's a lot of better understanding of the biology, better development of new therapeutics. And so you can see these medications, they're in various phases of development. Phase 3 is kind of the later stage. Phase 1 and 2 are kind of early stage diseases. So there's promise that we may have new therapies specifically designed for these diseases. All right, on the next slide. And I'll just leave you with this, that there's really, I think, hope for other rare kidney diseases. So just as we've understood the complement system better, there's really exciting advances in many of our kidney diseases, including FSGS, including IgA nephropathy, including minimal change disease and membranous, that just so much work is being done. And the better we understand the biology, the better we're able to get to new therapies. All right, so I want to leave you with just a couple takeaways, I think, on the next slide. So one, the terms rare kidney disease and chronic kidney disease, they refer to kidney damage that's picked up either by decreased function of the kidney or blood and protein in the urine. It's not a diagnosis. It's just a term that there's kidney damage. For rare kidney disease in particular, the kidney biopsy is really helpful to know what the actual damage is there. And then for C3G and some of our other diseases, because we've learned so much about the biology, there's a lot of new testing that you can do even after the biopsy in terms of genetic testing, functional testing of the complement system, and other biomarkers that are relevant for the specific disease. And so this is such an exciting time for rare kidney disease. I think staying up to date on kind of research opportunities, new therapies, new discoveries, because the field really is moving quickly. And I hope that the way that I practice medicine today, I hope is very different from how it's going to look 5-10 years from now.
Thank you, Dr. Mariani, for sharing this amazing overview of rare kidney diseases and some of the challenges that patients may come up against when seeking a diagnosis. And so next we'll hear from Ms. Farley and learn a little bit more about her experiences in getting a complement 3 glomerulopathy diagnosis. So Ms. Farley.
Hello. So yes, I was diagnosed in May 2018 with C3GN, but it was a long road to get there. So I had 10 years of clear symptoms, but overall 22 years of signs towards this. So it took a long time. So starting back, looking at my medical records, starting at age 4, I had protein in my urine. And throughout my childhood, I continued to have protein and blood in my urine as well as blood pressure issues. I didn't start having clear symptoms until high school. I was in track and a lot of sports, and I started having chest pains. And again, the blood pressure issue came up as well as irregular heartbeats. And I started consistently getting visible blood in my urine. And so with that, they did a kidney ultrasound, which went nowhere, as well as a bladder biopsy, which went nowhere. So overall, at that point, I was told I was young and healthy and it was unexplained. Moving forward, I started having GI issues and vomiting daily, and as well as having headaches weekly. So after multiple years of this, and also confirming I did not have stomach ulcers through endoscopies, I went to my medical center at my university, and I was currently in a hypertensive crisis, they said, and I was at risk for stroke and heart attack. So they put me on blood pressure medicine, and they also ran blood work, and that indicated some kidney disease signs, including low albumin, high creatinine, and low BUN. And I had seen some of these abnormal blood results previously on and off, but never at the same time. And I didn't know that it indicated kidney disease. And so they sent me to a local nephrologist. Before seeing that nephrologist, I did get another kidney ultrasound. So that was roughly 10 years since the one during high school. And this one, the results actually said indicative of kidney disease. When I went to see this nephrologist, though, he said I was too young to have kidney disease, especially since the blood pressure medicine was regulating my blood pressure. His recommendation was to eat more protein to bring up my albumin, which, if you know from the current presentation we just watched, that is inaccurate. And there's many diseases and kidney diseases that start in adolescence. And so I went and got a second opinion, thankfully. And that nephrologist had me go get a kidney biopsy. And so with that results, it came back as 75% scarring. And so I was in late stages of kidney disease, and it had dense deposit disease as the diagnosis, which is a type of C3G. And when I got this diagnosis, it was actually just uploaded onto my chart. And so I didn't have a discussion with a doctor about that. So I did Googling, which isn't a smart decision, but also because I was in a PhD program, I also went to journals, but both were very grim outlooks for C3GN. And so I wrote down 4 pages of questions for that nephrologist and faxed them over. When I eventually did meet with him the following week, he indicated that he understood his limits as a general nephrologist and said I needed to go see a specialist. But he warned me that I would probably need a transplant soon. And so from there, I contacted every specialist in the country that I could get a hold of. I sent my results to and met with about 10 nephrologists that first year until I found one that I really trusted. And it ended up being a 7-hour drive from where I was, but I was willing to go to that extreme, just so I knew I had a care team that I knew I could trust, especially knowing now that 22 years of signs were missed. And at that point, we did another biopsy and genetic testing to confirm the diagnosis. And then I continued on to multiple treatments, eventually dialysis, and then a transplant.
You know, and I've been a nephrologist for now over 20 years, and I've made this diagnosis, you know, like Dr. Mariani mentioned, only a couple times. And so what impact has living with, you know, among the rarest of rare diseases had on your daily life?
So I think generally symptoms and time commitment make the biggest impact on daily life, and specifically on relationships with family and friends, and then a timeline for life in general. So there's a lot of symptoms that start early, but then also progress to be significant factors in your daily life when you get into kidney failure and dialysis. So some of them being fatigue. I know you have to know fatigue to know fatigue, but there's times where you don't have energy to move, even if you're hungry, have to go to the bathroom. It's it really limits your ability to live life, as well as brain fog and memory loss, which was fun when I was in my PhD program. So I had to switch how I memorized things and how I read articles in order to do my research. Nausea was a big one for me. Like I said, I was vomiting daily. Body aches and joint pain was also a big one. And then just being immunocompromised makes a big impact. Having to wear masks, be careful around sick people, and just limiting how you interact in public really affects daily life. And with that, really affects relationships with family and friends. If you are so fatigued not to get out of bed, or unable to go to a public area like a concert, you lose a lot of friendships if they aren't flexible and understanding in that situation. And then time commitment. Just as an example, when I was on dialysis, I had 35 hours a week dedicated to dialysis, on top of taking daily medicines and organizing those medicines, doctor's appointments, other treatments like iron infusions, monitoring your blood pressure daily. And then a big one, which I did not expect, is also insurance and billing admin, and arguing and getting pre-approvals and appeals. Takes a lot of time. But all of this together, the time commitment and the symptoms, really changes like career trajectory and family planning in general.
Yeah, amazing. And all of this while you're pursuing a PhD as well, too. For many patients, it's extraordinarily distressing not knowing what's going on. And can you talk a little bit about the emotional toll of seeking a diagnosis, and then what it felt like after you finally got one?
Yeah, so like I said, my main symptom was throwing up daily. And so that really affected how I navigated school and events. And so I'd always be thinking and nervous about going out for that. So I was really looking for a diagnosis. So when I did get a diagnosis, there was this aspect of relief. But then when you go into the actual diagnosis of dense deposit disease and C3GN, and hearing that it's an incurable, ultra rare disease with no disease specific treatment, it can be a little scary, especially with the stats of majority of patients with C3 going to kidney failure within 10 years of diagnosis. And then 50% of patients, transplant patients with C3GN, experience graft loss. So it's a mix of emotions getting that diagnosis.
Yeah, and do you have any advice for people who may have been diagnosed with kidney disease but are still trying to figure out what their diagnosis is, sort of people who are a little bit earlier on in their journey?
So I would say keep going until you find a diagnosis. There will be a doctor that will actually listen and hear what you're saying. I had to go through a lot to get there. And I think now there's more understanding and awareness of rare diseases. And so hopefully you can get that diagnosis faster. But you know your body better than anyone. And so you know when something's wrong, and to continue to pursue that diagnosis is very important, and to advocate for yourself in the medical field.
Yeah, and you mentioned this this real emotional and psychological toll on relationships, and how have you used and how have you sort of reconnected with people sort of after you've had a kidney transplant, and now you're well aware of this diagnosis, and there's all these moving therapeutics that Dr. Mariani has mentioned?
Yeah, so before a transplant, like you're aware of even how your face moves and how much energy that takes, and just not having the memory of certain things that they may have said last time you're there, not having the energy to go and canceling last minute really affects some relationships if they're not understanding. And so just being able to have those relationships again and foster them again and going to visit people and is very important and is nice. It's nice to get back to those relationships and hobbies.
Thank you, Ms. Farley, for sharing this incredible story and your amazing resilience through pursuing a diagnosis, and then, of course, all of the challenges of treating, C3G. And so, what I'd like to do as we're kind of closing is to go back to Dr. Mariani and Ms. Farley for their sort of closing advice, like one important thing to know about rare kidney diseases, or one thing that you would recommend for our audience to do. And I'm going to start with Dr. Mariani.
Yeah, Michelle, thanks for telling your story. It's just an incredible journey that you've been on. I think I'm going to echo actually what Michelle said. I think, this is a field where these are rare diseases where I think the average nephrologist really only sees a handful, maybe over their whole career. And so I think you're right. Don't be afraid to ask your nephrologist if you should get a second opinion. I think it's sometimes actually, I love it when my patients want to double check my work. I'm like, that's great, because there's so many things we don't know, and that's okay. So don't feel like you're hurting anyone's feelings or anything like that. I would never worry about that, because the field is changing so fast. There's new testing, there's potentially research opportunities, there are new therapies coming out all the time. And I do think the nephrology field, because there in the past couple of years have been so many exciting new discoveries, that I actually do think the culture, I hope, is changing a little bit, where people are excited about those new opportunities, those new therapies, and really kind of embracing that. Whereas maybe, in the past, when there weren't anything to do, it felt a little bit hopeless to even go on those diagnostic journeys.
Ms. Farley, one thing to know or one thing you recommend?
I would say having a rare disease, you become your own doctor. And I think that's an important part, to have a partnership with whichever doctor you're working with. And so I bring articles in, printouts of trials, and we have friendly debates, and I make sure that I'm advocating for what I think, hearing them. And if you don't have a doctor that's supporting that type of conversation, I think you should find one. And then also just getting involved within rare disease spaces is important. So I know with my disease, we have a Facebook page where we stay in touch and can stay up to date with what's going on. Or with my disease, there's a patient conference where we can get new information, and looking at, for instance, the clinical trial page online, and just staying up to date and connected within rare diseases is important.
Well, thank you both for sharing your stories and your expertise. So in closing, I want to highlight AKF's Know Your Cause tool. It's a digital resource to help you learn about identifying the cause of your kidney disease. And so you'll answer a few questions, and then the tool will guide you through some talking points and questions to potentially ask during your next medical provider's visit. Thank you all again for joining us today. A special thanks to Novartis and Otska for making today's webinar possible. So once we conclude this session, you'll see a brief survey pop up. Please take a minute to fill that out and tell us how we did. Your feedback will be very important as we plan future sessions. We encourage you to explore the Know Your Cause tool to learn more about your kidney disease cause. Thank you everyone for joining us today.
The very first symptom that I had was in February of 2022. Started waking up randomly with lower back pain. Out of nowhere, I was just really tired all the time. It felt more than usual. So I ended up ignoring it actually for a couple of weeks, until one day I went to use the restroom and my pee had blood in it. I couldn't afford to ignore that. So I went to my primary care doctor. She ordered a bunch of tests, and we found out that I had blood and protein in my urine and that my kidney function was at around 70%. And she referred me to a nephrologist. During that time, I was really anxious. I didn't really know what to make of it or how to feel. I didn't know how serious any of it was. At that point, I was ready to find out what was causing it and how to fix it. When I saw the first nephrologist, he was really convinced that I just had a UTI. I felt like he didn't really know what to do with me, and he was just kind of going through the motions and forgetting about me in between appointments, and then looking at my labs and being like, oh yeah, what are you doing here? Stuff like that. Every single day, I was like, is today the day that I finally get answers, or am I just gonna get pushed to the side and forgotten about, basically? I went into my patient portal to pull out my labs, and I looked over them for the first time on my own. And in that moment, I realized that my GFR had fallen under this nephrologist's care. So basically, my kidney function had dropped from in the normal range to close to needing dialysis. My family had been pushing me to get a second opinion. Finally listened to them, and I looked for a different nephrologist. My main concern was finding out, is a biopsy the right next step for me? And so when I asked him that, he said, yeah, I think you probably should have gotten it done a while back. He said, I bet you have a glomerular disease, and we need to figure this out. I think it was 2 weeks later, I had my biopsy results back, and I found out that I had IgA nephropathy. I was feeling a lot of things. I was angry because I felt like it could have been solved so much sooner. And I think I felt relieved. I think self-advocacy is so important to me because without self-advocacy, I wouldn't have gotten a diagnosis. I started buying more zebra print things after I was diagnosed with IgA nephropathy because zebras are the symbol for rare diseases. Starting conversations with other people, whether they're patients or just a regular person, is so special because I get to share my story and then also raise awareness about IgA nephropathy, because you never know who's dealing with a kidney disease that doesn't know about it. They're so underdiagnosed and not talked about enough. I think if I were to give advice to someone who's at the beginning of their diagnosis journey, I would say living with a rare disease is challenging. There are definitely ups and downs, but there is life after diagnosis.